Good morning, and welcome to our first in our webinar series on the National Baptist Convention USA Incorporated 16th, virtual 16th Annual Health Fair webinar series. We'll be starting shortly. Let me bring those folks in. Okay, because of broadcast.
John is an attendee, right? Good morning, everybody. Good morning. Good morning. Welcome. Welcome. We are so glad that everyone is here with us for our for this morning's webinar. This is the Hope Ministry of the National Baptist Convention USA Incorporated. Dr. Jerry Young is our illustrious president. We are going to be talking today about the new normal. Same need for African American research. I'll say that again because it's something to really ponder on even before our panelists start talking. New normal, same need. Addressing the need for African American health research. We are so blessed and so happy this morning to have with us three very skilled presenters who are going to talk to us about research and how we are to address this new normal same need. We have doctors, all three of these ladies, Drs. Anita Fernander, Dr. Lavora Williams, who is a member of our HOPE team, and Dr. Brandy White. I'm going to do really brief introductions of these ladies because I think once you hear them speak, you're going to already get a really good understanding of their expertise, their spirituality. All of that is going to come out as they begin to speak. I'll start by introducing Dr. Lavora Williams, who again, I'm pleased to say is a member of our HOPE team, and I consider her a sister and a friend. Dr. Williams is an associate professor at the University of Kentucky College of Nursing. She recently joined the College of Nursing. Prior to that, though, she was a tenured associate professor and director of diversity in the College of Nursing, Augusta University, which was formerly known as Georgia Regents University and the Medical College of Georgia there in Augusta. She received her PhD in nursing from Georgia Regents University in 2011. And Dr. Williams' dissertation examined diabetes predictors among African Americans in a faith-based setting. In other words, her dissertation addressed some of the needs of the folks in our population that we serve in our National Baptist Convention USA. Her research focused on delivering interventions to reduce health disparities among minorities and medically underserved populations. Dr. Williams is a nationally recognized leader for developing culturally adapted interventions for implementation by community health workers. Welcome, Dr. Williams. Glad to have you.
Thank you.
Our next presenter, Dr. Anita Fernander. I'm going to bring her picture up. Good morning. She is Associate Professor of Behavioral Science at the College of Medicine at the University of Kentucky. She received her PhD in Clinical Health Psychology from the University of Miami, has a master's degree in the same, and holds 2 bachelor's degrees, one in physical education and the other in psychology from Oakwood College, which is now known as Oakwood University, an HBCU in Huntsville, Alabama. Her primary area of research and teaching has focused on examining the impact of race-related stress on disparities among African Americans. She teaches the following courses: Race, Racism, and Health Disparities Among Blacks in the USA, the History of Medicine Among Blacks in the U.S., Implications of Health Disparities, and Introduction to Clinical Medicine. Her scholarly passion is focused on increasing the number of underrepresented minorities in areas like medicine, promoting diversity, inclusivity, and academic medicine. Good morning. Welcome again. Our next person that we want to bring up is Dr. Brandy White. Good morning, Dr. White. Dr. White is an associate professor, at the University of Kentucky College of Health Sciences. She's an associate of the University of Kentucky's Building Interdisciplinary Research Careers in Women's Health program. She focuses her research on primary and secondary stroke prevention for medically underserved populations. Prior to joining the faculty at the University of Kentucky, Dr. White was the founding program director of the Bachelor of Science in Healthcare Studies program at the Medical University of South Carolina. Her PhD is in health and rehabilitation science, and she obtained it from the Medical University of South Carolina. She has an MPA in community health education from the University of Minnesota, and she also holds a bachelor's degree from the University of Miami. So welcome, ladies. So glad to have
Thank you.
all three of you present this morning. Again, I want to acknowledge the National Baptist Convention USA Incorporated. All right. Again, I want to acknowledge our convention, National Baptist Convention USA Incorporated. Dr. Jerry Young is our president. Also want to acknowledge our Hope Health Ministry, which is the health arm of the convention. Our leadership for that initiative is Reverend Dr. Michael Miner. He leads that particular portion, and then we have he leads the ministry, and then we have a training component that is led by Reverend Bernard Montgomery. What we're doing this year, because everything is different, we are facing a new normal. So in trying to adapt to this new normal, our goal this year is to have the same health fair that we've had for many, many years for our convention. But it's different. It's going to be virtual. This is actually our 16th year of having a health fair. So what the Lord placed upon the hearts of our leadership was to develop a virtual health fair series, which I am sure is going to really encompass more than the in-person health fair would, because people are going to have an opportunity to hear presentations by experts in their field, like these ladies who are going to be speaking today. We're going to have a little bit more of an opportunity for dialogue because of the chat functions and all the different things that technology offers us. So I'll submit that this may even be more effective than what we would have had in person, because we can really dive a little bit deeper into some things. I want to acknowledge a little bit more of our leadership for our Hope Health Ministry. We also have as our leadership Dr. Alvin Love, who is the chair of the Federal Faith-Based Development Initiative, and that is the umbrella that the Hope Ministry comes under. And then, of course, Reverend Dr. Michael O'Miner, who's our National Director of Hope and the Hope HHS Partnership. I want to share a screen of a JPEG here, so that all of our viewers will know exactly what we're going to be doing with this virtual health fair series. And then we're going to deep dive into talking to our speakers for today. Obviously, today is our first of several virtual health fair presentations. Again, our title today is The New Normal, the Same Need for African American Health Research. You'll see on your screen here on Tuesday, we'll do another one. Tuesday afternoon, talking about COVID-19 lockdown, eating healthy on a budget. Thursday the 18th, maintaining mental wellness during COVID. Tuesday, we'll address our seasoned saints in their efforts to stay healthy and stay fit while we're on lockdown. Next Friday, we'll talk a little bit more about fitness in a more holistic way. And then finally, we'll end on the Tuesday the 30th talking about caring for the caregiver in the wake of COVID-19. And that particular presentation is going to focus on women as nurturers and caregivers, and all the hats that we normally wear, and then the additional hats that are being added in the wake of COVID. Please notice our website, www.hopenbc.com, or of course, you can always email for registration information, and you'll see a listing of some of the organizations that we've been blessed to have as sponsors of our Hope Health Fair. All right, we're going to go back to our ladies. All right. So Dr. Williams, we're going to start with you. All right. As churches began to reopen, can you discuss a little bit about the rate of the COVID-19 infection rate on African Americans compared to the infection rate of white Americans?
Yes. So our last webinar, we talked about how churches were beginning to reopen, and we are so very thankful for the opportunity to congregate again. But we have to stay aware that COVID-19, the pandemic, it's not over. So what we're starting to see is disproportionate impact of COVID-19 on African-American populations. For instance, African-Americans only comprise about 13% of the US population, yet they're accounting for 23 to 34% of COVID-19 confirmed cases. And what's even more alarming about that is that Blacks are dying at a rate of 2 to 3 times their proportion of the population. And we're seeing those numbers among the 32 states in the United States. For instance, so what that means is that African Americans comprise 27% of the population of Alabama, for instance, but yet they're 46% of the COVID-19 deaths. Georgia, 31% of the population is African American, yet 49% of the COVID-19 deaths are among African Americans. And Tennessee, 17% of the population and 35% of the deaths.
Wow. Wow. Those numbers are astronomical. But it speaks again to the disparities that exist within our community in general. So I guess we can say, unfortunately, that COVID is no different from many of the other disparities that we experience in our communities. And those states you mentioned, I noticed that a lot of those were in the South.
Yes.
I think you said Georgia, Tennessee, Alabama, Bible Belt states.
Yes.
So that addresses the fact that we are also anxious to obviously get back to our houses of worship. So it's forcing us to look again at how we can still be Bible Belt and do it differently to help protect a little bit as far as congregating and those types of things.
Yeah, yes, ma'am. That was just to name a few. We're seeing those numbers across the nation.
I know you spoke a lot in our last webinar about the new normal for the church in relation to COVID and how we are to try to do the very best we can to still exercise social distancing, wearing our masks, everything we can do. People staying home if they feel sick in any way. So that is a new normal for houses of worship, for the entire faith community, I believe. Why are African Americans more likely to die from COVID-19 than whites?
Well, you know, that's a good question. And just to build on what we talked about the last time, that there are conditions that people have, underlying conditions that makes them more at risk for COVID-19 complications. And part of that is age, over 65, chronic lung disease, heart disease, people who are immunocompromised, for example, a person who's undergoing cancer treatment, diabetes, severe obesity, chronic kidney disease. So what COVID-19 really has laid bare to us is that what we've known really for a long time is that African Americans carry a disproportionate burden of these illnesses. Just for instance, obesity rates, 42% of white adults are obese. So it's a big problem across the nation, but almost 50% of African Americans are. Diabetes rates, about 7.4% of whites have diabetes, but for African Americans, that number is almost double at 13%. Wow. And even with cancer, statistics predict that among African Americans, that the lifetime risk of developing cancer is 1 in 3. Now, statistics say that. God didn't say that. Statistics say that. So what that means is that we as a nation are at risk. However, what's particularly concerning for Blacks is that when cancer is diagnosed among our population, that oftentimes it's at a later state. And when it presents at a later state, then it's more difficult to treat and more difficult to manage. And then cardiovascular disease rates. We know that the rate of heart disease among Blacks is really lower than it is among whites. But what happens is we're more likely to die from heart disease. And we're more likely to have heart disease related complications, such as congestive heart failure. Now, all of these statistics really just say that because we carry this underlying burden of more disease, it puts us more at risk for COVID-19 complications. And we could talk about why we have these conditions, and we know that there's numerous persistent systemic factors that cause us to be very vulnerable as a people. And we could call it lack of healthcare access. We could call living in a racist system with high levels of stress, our living conditions, and all of these things just lead to us having an underlying inequitable health status in America.
Wow, wow, that is something to really think about. All the disparities I want to just remind all of our viewers of our website for HOPE. It is HOPE.NBC.com. And for those who like to view us on YouTube, if they'll go to that site, again, HOPENBC.com, and click on the YouTube image, you should be able to view us from YouTube, as well as on this particular forum through Zoom, and then of course Facebook as well. I want to move to Dr. Fernanda for a moment and talk a little bit more about the disparities. Dr. Williams talked about disparities in diabetes diagnoses, heart disease, the death rate of African Americans from heart disease. She talked about the death rate of African Americans from cancer, and of course, the number of people who are obese within our population. So what causes these inequities?
So as Dr. Williams indicated, there are some systemic and structural factors that really are some of the underlying reasons as to why these disparities exist and these inequities exist. And we've, as long as African Americans have been here in the US, over 400 years, we have suffered disproportionately disproportionate health outcomes. Through almost 250 years of enslavement where minimal or no health care was provided for African Americans, even though our bodies were abused and used for medical experimentation without benefiting from the medical advances of those experiments. We went through 100 years of Reconstruction and Jim Crow segregation with unequal and inadequate healthcare facilities, access and treatment for us. You add on to that 55 years of civil rights where racism and implicit bias continues to impact clinical interactions that we have with providers, and as well as treatment outcomes. This equates to over 400 years of historical and contemporary dehumanization of African American bodies and inhumane healthcare. Furthermore, the interpersonal and individually mediated lived experience of white racism against Blacks triggers epigenetically influenced responses in our bodies that damages over generations immune, hormonal, and neuronal physiological processes that lead to negative physical and mental health outcomes, which exacts a heavy toll that scientists have linked to higher rates of morbidity and mortality. And all of these factors lead to these systemic and structural inequities and social factors that influence our health.
Wow. Wow. So it's many, many layers. And it appears that we've peeled the onion back quite a bit to determine the cause of these inequities, but I have a feeling we're going to keep peeling. The more we learn, the more we grow, the more researchers like you all continue to do the great work that you're doing. We're going to learn more, and prayerfully and hopefully our country will take to the information that you guys are unpeeling and do the things that we need to do to turn around some of these negative statistics and to eliminate some of these disparities and inequities that have just plagued us for 400 years plus. It sounds like what you're talking about here is a term that I've heard before, a term that we use a little bit in our health ambassador training for the National Baptist Convention Hope Health Ministry, is the social determinants of health. It sounds like that's a little bit about what we're talking about. So can you expound a little bit on the meaning of that? Many of our viewers may not know exactly what that means, or they may not have had our health ambassador training.
Sure. So social determinants of health are conditions in the environments where individuals are born, where they live, learn, work, play, pray, and age, that include factors like economic stability, neighborhood and physical environment, educational opportunities, employment, community and social context, the healthcare system, as well as racism that's embedded within all of these social determinants, and racism that is a part of our lived experience as African Americans from day to day. So for example, if we were to look at economic stability, key variables include things like poverty, wealth, and employment. And we know that African Americans have higher rates of poverty than general populations or white Americans, that their ability to have wealth. And one of the things that builds wealth for us is home ownership. Well, the 41% rate of home ownership among African Americans is the same as it was in 1968.
Wow.
Whereas the rate of home ownership is around 75% for white Americans in this country. So we could go through all of these different social determinants of health variables and demonstrate the inequalities through education, through our neighborhoods and physical environments, and our social and community contexts, and our healthcare systems, that really, there are inequalities across the board that then subsequently have a role on our health. And these social determinants of health account for many researchers have found that they account for up to 80% of health risk.
Wow. That's shocking in a way. But then again, it's not shocking if you look at the historical context that you all have already presented to us. There is a school of thought. Some people will say that our behavior as African Americans, the things that we eat, the way that we live, our culture in general, causes these health conditions. Even some people within our own race will say that about us. So talk a little bit, if you don't mind, about that.
Yeah. So as I just mentioned, up to 80% of our health risks can be accounted for by the social determinants of health that I mentioned. Individual choices, individual behaviors, our genetics or so-called biological predispositions account for only a small part of our health risk. There's a term that says that our zip code has more weight or matters more than our genetic code when it comes to our health. And that's for the health of anyone, whether they're African American or any other racially classified social group.
Wow. That makes me think a little bit about years ago. I learned that the circulars for grocery stores oftentimes are different based on zip code. And I was floored by that. Yeah. And that's just a very common indicator that everybody across the board would understand, because everybody goes to the grocery store. Everybody glances at the circular before they put them in the big green can. So that's something to really think about when we talk about zip code. And I think that takes us back to systemic racism and those types of things that we've been talking about so much in our media over the last couple of weeks.
Absolutely.
So what does society need to do to move this needle to better address these social determinants of health?
Yeah. So as we're seeing now, there needs to be a coalescing of individual will as well as social will to address these social determinants of health. And it's because of the many layers, what you use the analogy of peeling the onion, because of the many layers and the complexity of these issues, it does require cross-sector collaborations and partnerships from just folks to really meet together and work together to advance health for everyone. But I think if we were to isolate it and break it down, I kind of conceptualize it in my mind into 4 different areas. So looking at health systems approaches. So our health institutions, they need to begin developing social risk factors in addition to biological risk factors to account for a patient's health and address those issues in clinical settings. We know that there are some healthcare providers and systems that are doing that. Kaiser Permanente is starting to develop social risk profiles for their individual patients, so then that clinicians can come in and not only just discuss how your medication for hypertension is going, but other issues that may be influencing your high blood pressure or hypertension status. When you think about health care professions training, we need to provide education so that our trainees are understanding the influences of the social determinants of health understanding what health equity is, educate trainees about social services resources that they can provide to their patients. They need to understand what systemic racism is, how implicit and explicit bias impacts their clinical rapport and treatment recommendations, and have a broad understanding of cultural humility and understand and exercise that as they interact with their patient populations. As far as the federal, state, and local governments, there's so much that can be done. Integrating services. We saw how difficult it has been to collect data by race when it comes to COVID-19 in a variety of states and counties. We need to mandate that the collection of data is accurate and consistent. Addressing healthcare professional shortages, increasing healthcare workforce diversity, initiating reparations programs. There's just so many. And again, as I kind of alluded to earlier, using some cross-sector collaborative approaches and partnerships to develop community equity teams that can advocate for their communities.
That's great.
And this is Dr. White. I'm going to jump in with cross-sector collaborations. There are a lot of creative ways that you all have engaged populations. And one project that we have going on, we partnered with the Housing Authority and a group of community members, and we're investing in our youth over a summer with the summer enrichment program, because the community recognized and the Housing Authority recognized that in this predominantly low income African-American community, our youth are missing out on a lot of these opportunities because of all of the inequitable systems that Dr. Fernanda talked about. So we really need these collaborations and partnerships to be creative. We got to think outside the box. So this youth program that we have, it's going to be unique because of COVID-19. So we're thinking about creative ways to engage our youth, but it's really focused on life skills enhancement and how can we increase their opportunities in this system that we're in? How can we give them the skills that they need in order to meet the goals that they set for themselves?
Oh, that's fabulous. So trying to start with high school girls hopefully will help change some mindsets early on, so that folks can again start to practice some better things for health and try to help themselves do a little bit better. Try to help eliminate some of the social risk factors that I think Dr. Fernanda was talking about. So thank you. Thank you very much. Dr. White, can you speak a little bit more about how the church can engage with academia and any best practices for community research?
The best thing, and it's something that you all are doing, is being able to work collaboratively with communities that are most affected by the issues that you're addressing. And that requires us to really accept the community members as experts. And as an academic, I can speak. It can be challenging sometimes because we're trained in this framework that education means that the higher educational attainment you have means that you're more intelligent and that you know what needs to be done. And that's not the case. And when we're talking about health inequities and medically underserved populations, that approach is not going to work. You have to meet people where they are, understand their needs, because they know their community best and they know what the issues are. So I talked a little bit about our partnership with the Housing Authority, but a way that we've really engaged residents, and it wasn't so much the Housing Authority that pushed it. It was a group of public housing residents, all African-American women, who wanted to do things in their community. They knew that the lack of healthcare access was killing them. They knew the lack of food, affordable, healthy food, was killing them. So being able to bring everyone together and including the housing authority. And we have other stakeholders that are really important, like the local health department. We're getting local healthcare clinics involved. That's really important to change from the community level to make things more equitable. And of course, as Dr. Fernander said, we still do need those systems to be more equitable, but really community empowerment, it can be that's one of our biggest assets.
Sounds like you're talking about doing things from the bottom up, pushing up, almost from a grassroots level, so that the ones who are the decision makers really see what the people are asking for and see what we're needing to become healthier and to do better in our communities. You talked a little bit about your projects with high school students. You've talked a lot about communities. I understand that you have some community research that focuses on healthy eating and physical activity. You have anything more that you want to share on those two things?
So I'll talk a little bit about our healthy eating project, and it gets into a lot of the health disparities that Dr. Williams talked about with cardiovascular disease. And if we look at hypertension, African-American population, our hypertension rates, and especially Black women compared to white women, are disproportionately higher. And so one thing that we can do to control hypertension or to prevent it is healthy eating. And as Dr. Fernander laid out, for a lot of medically underserved populations and a lot of our African-American populations, food insecurity and access to healthy foods is a big challenge. So when we tell people you need to eat healthy, and you say you need to get all these things that you may not have heard of, that's not even offered at your local grocery store, we're telling them to do this, of course they're going to be non-compliant.
Right.
Because you haven't given them the tools, the skills that they need to be healthy, or even ask them what they need. So with this project, it really emerged out of our community advisory board that we have of local public housing residents and students at our local university, which has also been a big asset. So students, whether in college, youth, they can be phenomenal advocates for community change. But healthy eating was a big challenge because the local grocery store doesn't have the best food. It's not affordable. The Walmart isn't within walking distance and the food there isn't always the best. So when we were talking about ways that we can prevent and control hypertension, a lot of clinicians, there's this diet that we can implement called the DASH diet, and it reduces our sodium intake. And we were looking at this, and a lot of the recipes that it has, they're great, but they didn't meet the needs of our community. So right before COVID-19 happened, we were in the process, the community members said, well, you know what if we submit our recipes, some of our favorite recipes, and you all tell us how we can make them healthy. So we have a project that's continued on into the summer, and we're thinking about how can we be creative in disseminating this information to people. And something that we've decided as a committee is to start hands-on with something that people can use, and that's a crock pot. Give people a crock pot, come up with recipes that are affordable, that you've purchased from the local grocery store, so you know that people have access to it, and that's easy to make and healthy, low calorie. It's a lot of food, but it's also something that they like. So that's something that we're in the process of doing, and something that we've heard is that a method like this and having cooking classes with the crock pots may be feasible for us to do it that way. So that's one project. COVID-19 has changed how we operate and how we engage residents. So that is a challenge, but it's forcing us to be more creative,
Mhm.
and it gets us to think outside of the box.
Absolutely. Wonderful. That is so true. We do have to think outside the box in almost everything that we do as we face COVID, the new normal. So thank you very much. Thank you. We're going to go back to Dr. Williams. And we've talked about community-based research. Dr. White talked extensively about that. So can you just give us some examples of church-based research?
Yes. On our last call, we talked about COVID-19 and how it was impacting African Americans. And the project that Dr. Fernando and I are involved in now it came out of some editorials that we were writing. And what we were hoping through those editorials was to show that to just stop this narrative that somehow Blacks were being blamed for having COVID-19. So what we were trying to expound upon through those op-eds was to help people understand that our situations are different. So through that, we developed a project. It's a survey-based research where we're trying to get data that compares white churches from African-American churches. And we're looking at how COVID-19 impacted the African-Americans and whites, their finances, their mental health, their behaviors related to COVID-19, their attitudes regarding all of the prevention guidelines related to COVID-19. And what we're hoping is to show through data that African Americans took the COVID-19 pandemic as seriously as the white population. And what we're also hoping is to show is that COVID-19 did have a differential impact on African Americans. And what that will do is that will lead us as we go into vaccine for COVID-19, helping policymakers to understand that African Americans, number one, are more vulnerable, and making sure as we move into the next step of COVID-19, of addressing this pandemic, that we're allocating resources to these vulnerable populations. So that's a church project that we have going on. Another one that we did with Georgia, and I see some of my Georgia colleagues on the call, was Fit Body and Soul. That was truly a community-based research where the community came to us and said, we need an intervention to help us address obesity, diabetes, and cardiovascular disease within our churches. So we culturally adapted an intervention, and we worked with those churches to completely adapt that intervention to address their needs, to use the language that they use, to describe the foods that they had access to, and to have the training conducted through community community health workers, or health ambassadors, as we call them in the National Baptist Convention, to deliver those interventions. And what we hope in delivering it that way is that it would be sustainable, because the very last thing we want to do to a population is to go in with something excellent, and then once the research ends, pick up our microscope and all of our data and leave that community. So we wanted to empower them with the resources and equip them to carry on the intervention. Now, through that research, we learned that one size interventions doesn't fit all. So the project that we are hoping and praying for funding for now is to look at individuals who are not progressing at the rate that the larger part of the group is. And we're developing an intervention that's completely adaptable to them, that meets their unique needs and helps them be more successful with the intervention. And then lastly, through the National Baptist Convention, we're seeking funding to partner with the National Diabetes Prevention Program, because oftentimes there are resources available in our communities, but as a people, we sometimes are completely unaware of those resources. So we're hoping with the help of our National Baptist Convention ambassadors and the CDC that we can connect individuals to those ongoing National Diabetes Prevention Program resources.
Wow, that is wonderful. That is work that needs to be done, should have already been done. So we are so thankful that you ladies are leading the way for this. I'll be bold and I'll say I'm thankful that the researchers leading the way are people who look like me. That means a lot. In all seriousness, you know, it's funny, but then it's true. It means a lot in our communities.
Amen.
Mentioned how oftentimes the researchers will come in, take our intellectual property, you know, our knowledge, take things about our culture, get what they need for their project, and then pack up their microscopes and leave. And sometimes, not all the time, but often, those researchers are not folks who look like us. So I think having women of color leading the way for this project is just absolutely phenomenal. As a convention, we are doing everything that we can through our Hope Health Ministry to try to make sure that our member churches and the communities that they serve are as healthy as they can possibly be. You ladies have mentioned through the course of this conversation, you've mentioned a lot of the things that we talk about in our Hope Health Ministry, a lot of the things that are part of our health ambassador training. You've talked about the fact that our communities need to be empowered. After 400 plus years of systemic racism, we're at a place now where we do need empowerment, starting at the grassroots level, starting at the community, meeting people where they are and working with them from that particular place. We've learned through you all today and then through our work, through our health ambassadors, that of course one size does not fit all, because we're all very unique. We're all different, but we do have one thing in common. We know, and I think Dr. Fernanda mentioned it, is that 80% of the health risk that we have as a people is due to those social determinants of health. So again, what our Hope Health Ministry tries to do is look at those determinants, meet people where they are, use our pulpits as a bully pulpit of sort to get the word out to parishioners, and to the communities that our churches serve. One thing that we do is work with the All of Us research program, which is a program that comes through the National Institutes of Health. And it talks about precision medicine. Now, we've talked a lot today about foods, about cultural biases. We've talked about systemic racism. We've talked about diet and all those things. But medicine, I think one of you mentioned the clinical rapport that happens between provider and patient. Teaching providers how to better medicate people of colors, taking into account our genetic code, our zip code, our culture, our history, and what precision medicine does is look at all those things from a new perspective. I think they have a different lens from what people have had in the past. And as a convention, we've been blessed to work with precision medicine to get the word out about this All of Us research program. We know that President Obama pushed precision medicine early on in his presidency, and we are so thankful that we're still having an opportunity to do some of the work that he started. The whole idea is to find 1 million unique people of color, and those can be Black or brown individuals. 1 million people in general, obviously. I'll rephrase that. We want 1 million people. NIH and Precision Medicine, the All of Us program, wants 1 million people to participate in this program. Our convention, of course, is focusing on our constituents, which are people of color, to participate, to find ways that we can stay healthy, ways that we can better address the health disparities that exist within our populations, and find treatments and medicines that are best for us. It's something that may not necessarily help those of us who are live here for this call, for this webinar, but future generations will benefit exponentially from the work that that program is doing. I want to go back for a moment to Dr. Fernanda to talk a little bit about, a little bit more about precision medicine. And I am sure that she can address it much better than I possibly could. There we are.
You did a great job talking about it.
Well, bless you.
Precision medicine really is a concept to really be able to produce better outcomes and utilize information to be able to target individuals and to provide treatments that are going to be more successful. With precision medicine, there's a large emphasis on using the genetic code, someone's genetic code, their biological history. But we want to make sure that we keep, when we think about precision medicine and its usefulness into proper perspective. And one thing that's important to remember in keeping it in its proper perspective is that what precision medicine is doing is really providing an opportunity for practitioners to develop treatment recommendations based upon gene environment interactions, which are commonly referred to as epigenetics. So how do things in one's environment, how does that 80% of the social determinants of health act upon or influence the body's ability to respond to various external and internal, for lack of a better word, stress that it's presented with. Things like stress, pollution, diet, other social and environmental factors, they do activate a sequence of physiological processes within our bodies. So that really is the idea of what precision medicine is all about. And I congratulate NBCUSA for really participating in this effort and highlighting it, and really playing a huge role in the health effort for our community.
Wonderful. Thank you very much. Thank you. Ladies, we thank you all for your time. We thank you for your expertise. We thank you for the work that you do to help all of us become healthier, to help us become more educated about the health environment in which we live. And we thank you today for helping us learn a little bit more about the new normal and the same need that we face for African Americans in research. We appreciate you. I want to do a gallery view so everybody can see you all once again. Give yourselves a hand for a job well done. And I love the collaboration that it took from the three of you to make all of this flow very beautifully. We appreciate it. National Baptist Convention USA H.O.P.E Health Ministry appreciates you. I want to take a moment to talk about our upcoming webinars that I mentioned earlier. Just a reminder, This is the first, or this was the first of our virtual health fair webinar series for our 6th annual Hope Health Fair. Our next webinar will be on Tuesday, June 16th, 1:30 p.m. Central, 12:30 Eastern Time. And the topic will be COVID-19 lockdown, eating healthy on a budget. And all of our panelists today addressed a little bit of that by talking about food deserts, the lack of access to grocery stores within our neighborhoods, even talked a little bit about how we can utilize crock pots and things like that to stretch our meals, to prepare foods that we will enjoy, but that will at the same time be healthy. And of course, we talked just briefly about how the system sometimes puts us at a greater in a greater state of need just because of the food that is provided for us in our neighborhoods or that is advertised to us in our neighborhoods. So we're asking everyone to please join us on next Tuesday for that. In addition to thanking our panelists, I'd be remiss if I did not thank all of our viewers who are watching via multiple social media platforms. We have some that are viewing via Zoom. We have some that are viewing via YouTube, and we have others that are viewing via Facebook. And we're asking that everyone please share the information that you learned today. If you know someone that needs to hear this that may have missed it, please direct them to our NBC Hope website so that they can view. Again, I want to acknowledge the All of Us research program, which is making a very, very strong effort to stress the importance of precision medicine and to really address a new term that we learned today from Dr. Fernanda, epigenetics, and around us and our environment can impact our health. And how our bodies react to treatments and to medications. And then, of course, the whole concept of patient-centered care. Providers learning how to address us and meet us where we are. And then in turn, our communities learning to interpret what our providers have told us and take that information and use it to our benefit so that not only we can become healthier, but future generations of folks who look like us can be healthier. All of us simply wants to create a culture of health across the board. And again, National Baptist Convention USA Hope Health Ministry is very happy to be able to help push the All of Us Research Project. And we encourage people to go to our website if they'd like to learn more about All of Us and become one of the 1 million participants that are going to help to move the needle for healthcare in our country. Again, we want to acknowledge our leaders in our convention, our leaders of the Hope Health Ministry, Dr. Minor and Pastor Montgomery. We want to address Dr. Love, who is over all of our faith-based initiatives, and of course, our convention president, Dr. Jerry Young. Ladies, thank you again, Dr. Williams, Dr. Fernanda, and Dr. White. We appreciate you. To all of our viewers who are viewing from all these various platforms, thank you for joining us. We thank Dr. Minor for being our technical person today. I'm usually the one who's in the corner writing him notes and making faces and holding up my fingers and doing sign language. So I appreciate him for doing that for me today. We're going to ask if anyone has any questions for our panelists before we move on. Okay, and you can pose your questions in the chat feature if you're viewing via Zoom. Or you can type it in to our Hope email address. And we're going to give you just a second. All righty. We don't see that there are any questions at this particular time. Again, remember that you can go to www.hopenbc.com for a complete schedule of our future webinars. For panelists and attendees, we're going to ask you that you hang on for just a few minutes as we sign out of YouTube. Again, thank you, everyone. Be blessed.